report will be about the role in the treatment of metastatic renal cancer with method of radiotherapy. For a long time, remain a high percentage of patients with metastatic renal cancer, about 20%, and 5 years survival in this group less than 20%. Let's start from the beginning and a little bit of history. In the year of my birth, there was published an article by Jerome Wyatt. He was very famous researcher in the world in advanced technology of radiotherapy. He was president of American Radio Society in 1974 year. In which study and which article he already wrote. Radiation therapy occupies an important role in the management of malignant renal tumors. Relatively high total doses of radiation are necessary to achieve tumor sterilization or even regression. It was 44 years ago. But 10 years later, published the results of study Edward Halperin, very famous researcher too. In the article results were disappointing. Only 30% effect of treatment metastasis central nervous system. And conclusion were mistaken. He concludes, no relation between TDF equivalent dose of radiation administered and frequency of palliative response was found. In those sites where response of bone pain to radiation was observed, 86% of the responses last the remainder of the patient's life. No correlation was found between TDF equivalent dose of radiation administered and duration of response. Radiation may be a useful palliative tool for bone pain and mass effect from metastatic renal cell carcinoma. Inordinately high doses need to be used to achieve the desired effect. And wrote, radiation therapy has had limited success in our hands for control of CNS metastasis. Hopefully, advances in dose distribution or radiosensitivities will improve the results of palliative CNS radiation of renal adenocarcinoma. But let's return to the present. A little bit about histology. Histological one-cover classification. There are three main renal cell carcinoma types. First is clear cell renal cell carcinoma, around 80 or 90%. Second, papillary renal cell carcinoma, with two subtype of this type, first and second, about 6 to 15%, and chromophobe renal cell carcinoma from 2 till 5%. Clear cell carcinoma and type 2 of papillary type have a propensity for metastasis and worse prognosis. Before treating, it is necessary to know where to look for. In the first place, in the distribution of metastatic sites in metastatic renal cell carcinoma is lung. And there are bone, lymph node, liver, and brain. The rate of single-site metastasis about 60%, and rates of metastasis at 2 or more sites about 40%. The rates of bone metastasis from 10 to 50%, and the rates of brain metastasis from 2 till 16%. We address to the guidelines. What is told by National Comprehensive Cancer Network? Only ablative techniques of metastasis in selected patients who are not candidates for surgery. No more. What is ablative techniques? It is radiotherapy, stereotactic, or other techniques without radiation, maybe. Other guidelines from ESMO. For the subsets of good prognosis patients with a single unresectable brain metastasis, stereotactic radiosurgery with or without whole brain radiotherapy should be considered. And only. Well, what to say? European Association of Urology wrote, no general recommendation can be made. The decision to resect metastasis has to be taken for each site and on a case-by-case basis. Performance status, risk profiles, patient preference, and alternative techniques to achieve local control must be considered. In individual cases, stereotactic radiotherapy for bone metastasis and stereotactic radiosurgery for brain metastasis can be offered for symptom relief. Do we really have so little? Let's go side by side. Firstly, brain metastasis. My report is some literature review with some examples. One of the large studies by Seastone and Chow has 166 patients with 487 metastases. Was stereotactic radiosurgery treatment delivered dose from 50 to till 35 grays by Lexel gamma knife. And the results of this study. Local control was obtained in 19% of patients. This line, one target, and this line, 2 or more targets. Patients with one lesion targeted for stereotactic radiosurgery tended to have a longer progression-free survival. Other study from Japanese researchers from Tokyo has 35 patients. It was be stereotactic was be 3 modality of treatment: fractionated stereotactic radiotherapy, surgery and follow conformal radiotherapy, or conformal radiotherapy. Overall survival very good in the group of fractionated stereotactic radiotherapy. Conformal radiotherapy, no good results. And surgery with following conformal radiotherapy, so-so. The role of whole brain radiotherapy. When talking about brain irradiation, there is always the question of whole brain radiotherapy. What is better, whole brain radiotherapy or fractionated radiotherapy or stereotactic radiotherapy? About it, this study from German group. 88 patients, 51 patients part with stereotactic radiotherapy, 17 patients in group with stereotactic radiotherapy with whole brain radiotherapy, alone whole brain radiotherapy, 20 patients. Stereotactic radiotherapy median dose was 19 grays, from 20 till 20, from 15 till 22 grays. Whole brain radiotherapy was delivered by 3 gray and 10 fractions, or 2 gray in 20 fractions. Results. Overall survival. This line, stereotactic radiosurgery, stereotactic radiosurgery with whole brain radiotherapy, alone whole brain radiotherapy. But stereotactic radiosurgery with whole brain radiotherapy compared with only stereotactic radiosurgery, comparison not significant. And stereotactic radiosurgery with whole brain radiotherapy compared with stereotactic radiosurgery. Entonces, overall survival in group of stereotactic radiosurgery, 12 months. Stereotactic radiosurgery with whole brain radiotherapy, 16 months, but comparison not significant. A whole brain radiotherapy, only 2 months. Additional whole brain radiotherapy to the stereotactic radiotherapy improved intracranial, intracerebral control. It is significant data. For example, from our center, a pacemaker was implanted to the patient with kidney cancer because of cardiac arrhythmia. Then a pacemaker was replaced with another one. After that was diagnosed neurological deficit, and after that made CT scan of the brain. He diagnosed metastasis in the brainstem from renal cell cancer. We treat this man, 70 years old, with single fraction stereotactic radiosurgery, 20 grave delivered by cyber knife. Tumor volume was 16 cubic centimeters. In this case, was without MRI fusion because patient has a pacemaker. It was some problem, but after 5 months of treatment with radiosurgery, patient has PET-CT with 80 fluorotirazine, we can look a little bit radiopharm contrast. Follow-up of this patient is 10 months after stereotactic radiosurgery. Now patient alive and reduce neurological deficit. Conclusion in this part of TEAM. High single-dose image-guided radiotherapy provide for high local tumor control for brain metastasis, for brain metastatic renal cell cancer. Additional of whole brain radiotherapy to the stereotactic radiosurgery improved intercerebral control, but not overall survival. Additional of whole brain radiotherapy may be for patients with multiple brain lesions, and for all patients with any minimal regional neurological symptoms, it is important to do a CT or MRI scan of the brain for a diagnostic possible metastasis. Let's go. One side, next site, bone. What is the role of radiotherapy of the historically radioresistant renal cancer? There was comparison of two methods, conformal radiotherapy and stereotactic body radiotherapy. In this study was 44 patients with 95 lesions. 50 patients has stereotactic body radiotherapy, and 45 patients conformal radiotherapy. Conformal radiotherapy was delivered by 20 grays in 5 fraction, stereotactic body radiotherapy, 27 grays in 3 fraction. Results of this study. Stereotactic body radiotherapy and conformal radiotherapy. Median time to symptom control, stereotactic body therapy was 2 weeks and conformal radiotherapy was 4 weeks. Radiographical local control has same results with clinical data. Bone metastasis from renal cell carcinoma, stereotactic radiotherapy and fractionated stereotactic radiotherapy. This study from Michael Zelewski and Yoshia Yamada from the New York, different sites of bone metastasis, pelvic, femur, spine, and other. And his results. Blue line, it is hypofractionated radiotherapy, and blue line, it is single dose radiotherapy or radiosurgery, and red line, it is fractionated radiotherapy. 105 patients was observed. Main results: 3 years local relapse-free survival, high single dose, 24 grays, 88%. Low single dose, less than 24 grays, already only 21%, and hypofractionated radiotherapy only 70%. I think that diagram is clear. Blue line is single dose radiotherapy with 24 grays, and green line single dose radiosurgery with less than 24 grays. Our experience, one patient with very difficult pain in the pelvis per metastasis in the sacrum and soft tissue, compression nerves, was treated by cyberknife stereotactic radiotherapy in 30 grays in 5 fraction. The tumor volume was 80 cubic centimeters. After treatment, pain relief, narcotic analgesics failure, and follow-up 70 months after stereotactic radiotherapy. Unfortunately, I cannot show you control CT scan. Conclusion: stereotactic body radiotherapy is both safe and effective for treatment renal cell carcinoma bone metastasis. High single-dose image-guided radiotherapy provide for high local tumor control for bone metastatic renal cell carcinoma. Lung side, unfortunately, no study has been focused on radiotherapy metastatic renal cancer, so I will show you our pictures as example. One woman, 59 years old, has 2 lesions in left lungs, third segment, and other lesions was in the spina iliaca anterior superior sinistra. Was treated by stereotactic radiotherapy in 4 fraction by cyberknife, 2 lesions. And our results before stereotactic radiotherapy and after 20 months. Other view, coronal, PET-CT, 2 lesions and no lesions. And finally, very important publication. It is a recent publication in this year. 84 patients, 175 lesions, stereotactic body radiotherapy in different total doses and different regimen of fractionation, all extracranial localization. His stereotactic planning, single isocenter, multiple beams of volume modulated arc therapy, margin for PTV 5 mm, conformity 85% PTV must be coverage, total dose from 8 to 60 grays, and number of fraction from 1 to 5. And so important results: local control by stereotactic ablative radiotherapy intent. This line curative and this line palliative radiotherapy. Local control by systemic radiotherapy. Local control by previously radiation therapy or without previous radiation therapy, and with radiation therapy in anamnesis, and local control non-spine spine lesions. His results: the first year local control, 1 year local control rate after stereotactic radiotherapy was 91%. And local files were associated with prior ablative therapy, palliative intent radiation therapy, spinal localization, previous systemic therapy status. Biological equivalent dose less than 100 and 15. Grace. Conclusion. Radiation dose received by 99% of the touch volume greater than 98 Grace was the strongest dosimetric predictor for local control. Multisystemic therapy status was independently associated with a higher local viral rates, suggesting the need for higher radiation dose. Based on the new publication, the thought that renal cell carcinoma is truly radio-resistant may no longer be true with current radiation treatment with stereotactic body radiotherapy. Thank you very much for your attention.